First of all, I'd like to thank the DIA Egypt group, Dr. Ibrahim Lebrashi, Dr. Khalifa, Dr. Nabil, Dr. Khattab, for inviting me. Actually, this hybrid meeting, we just finished the CardioAlex hybrid, and this is, again, the second hybrid meeting in such place. Actually, Dr. Sylvia made a lot for our talks, according to the cardiology and the nephrology. Regarding the heart failure with the patients with our unmet needs, when the heart failure constitutes about 64 million people worldwide, and the relationship between heart failure and diabetes is a 2.5-fold greater risk of developing heart failure than patients without diabetes. So the prevalence of type 2 diabetes in patients with chronic failure is 30%. The 5-year mortality is 50%, and despite the proven recommended treatments, those patients with heart failure are not receiving these therapies, but below the doses below the target. So the proposed treatment of therapy of heart failure, as you know, there are 3 types of heart failure with reduced ejection fraction, heart failure with preserved, and heart failure with mid-range. Regarding the heart failure with reduced ejection fraction, actually we have ACE, ARBs, ARNI, we have a beta blocker, mineralocorticoid, and finally we have SGLT2 inhibitors. We have two parts of action of SGLT2 in our patients' prevention of heart failure, and this could be the concern of diabetologists, and treatment of heart failure, this speaks the concern of the cardiologist. The SGLT2 and since the development of the discovery of this drug in heart failure with diabetes, cardiovascular risk factors, so preventions 2015, the MPEREG outcome, the rate risk reduction is 35%. 2017, the CANVAS program is 33%. 2019, declared TEMI 58, 27%. 2020, the VERTS is 30%, as Dr. Sylvia said in his talk. Diabetologists can now prevent heart failure through these 4 drugs. Regarding the heart failure, the evolution of heart failure management from prevention to treatment, as you can see, this is the normal ventricular function, and this is the end-stage heart failure. This is the window of opportunity for treatment between diabetes patients and non-diabetes. The preclinical stage of the disease, then the clinical stage of the disease, from taking 10 years, and then detectable cardiac involvement. As we can see nowadays in the last guideline, European guidelines concerning on the duration of diabetes. 10, less than 10, 10 to 20, and more than 20. This is very important. And when you look at these trials, CANVAS program declared TEMI 58 and the MPEREG outcome, this can prevent heart failure. Regarding when you have actually the cardiac involvement, so there are a lot of trials which I'm going to speak about: DAPA heart failure, deliver heart failure preserved, Emperor preserved, Emperor reduced, and SOLIST WHF. So the treatment, this found the treatment stage. Actually, in our field of heart failure, when I started at the residence, just have a diuretics, and then I starting the beta blockers, and then started the ACE and ARBs, and the use of isobutane nitrates, and the use of CRT, use of evabradine. Then we just recently have, in the last 5 years, 2 important drugs. One is the ARNI, and this is in paradigm heart failure, and the second SGLT2, which is in DAPA heart failure, Emperor heart failure. So the SGLT2 inhibitors actually has a good relationship nowadays with heart failure. Do you have wealth? Do you have health? Do you have practice? Yes. You have wealth of evidence, quality of life, safety measures, and finally the guideline and the future. Wealth of evidence, this is discovered in DAPA heart failure trial, which is published New England Journal of Medicine 2019. This is 4,744 patients, ejection fraction less than 40%, and the primary composite outcome, which including primary composite outcome, 26%, cardiovascular deaths, heart failure hospitalization decreased by 25%. Also CV deaths 18%, all-cause deaths 17%. So these results are very important in treatment of heart failure. Any relationship between these drugs and the quality of life, because ARNI is important in improving quality of life. Yes, the number needed to treat improved with more than points, 15 points. is the treatment effect of background therapy in relation to diuretics, mineralocorticoid, digitalis, ARNI, ivabradine. Actually, the consistent results by background therapy. So then finally, what about the patient without type 2 diabetes? Because actually, it's 45 in this trial, it's only 45% patients with diabetes, 55 without diabetes. So the effect of DAPA on worsening heart failure and cardiovascular death in patient with heart failure with the diabetes published in JAMA, this is important articles showing that the primary composite outcome in DAPA heart failure with diabetes equal to those without diabetes. And recently, in the last 2 weeks, with the European Heart Journal, this article published in August 29, 2020, about another drug, which is empagliflozin. Actually, this Emperor reduced trial time to cardiovascular death hospitalizations. Primary endpoint, actually, 462 patients with event rate, 21 for 100 patients. So this is very effective. The hazard ratio is 0.7, so rate of risk reduction 25%. As we can compare the Emperor reduced and DAPA heart failure for all-cause mortality, more or less the same. Regarding the total test for overall treatment effect, there's no difference between these drugs. And this is this drug by my friend Faiz Zanat. The health, the quality of life and safety measures. Yes, the quality of life is improved by the use of this evidence of DAPA heart failure, like the ARNI, with the quality of life improvements. The treatment of heart failure reduced ejection fraction, there is no side effects, maybe some form of hypotension. And then the practice guidelines. Do you have a guideline? This is a momentous victory in the war against heart failure. This is published by Deepak also by Bruno in 2019. As you know, these the three names are very important names in the field of cardiology. And they said that SGLT2 is the new pillar of heart failure reduced ejection fraction. One pillar is ACE, ARB. The second pillar is a beta blocker. We have a wealth of evidence beta blocker. And we have wealth of evidence in the EMPHAS trials and RALS trial for aldosterone antagonists. ACE inhibitor from starting from the SOLVIT to the CHARM and the VALHEF trials. The ARNI with the paradigm trial. And finally with the DAPA for the DAPA heart failure. So the sodium glucose cotransports, the two inhibitors of heart failure, this is the position paper of the Heart Failure Association of the European Society of Cardiologists by the whole names, the names Peter Sivoric, Gracos, Mullens, Robert Ferrari, and all of these heart failure specialists, that it is important in the patient with or without diabetes. But nowadays we are looking for another form of heart failure, which heart failure preserved ejection fraction. We have two trials ongoing. One is with the DAPA, with the preserved ejection fraction, and the second with the Emperor, which is Emperor preserved ejection fraction. Finally, from prevention treatment, Mr. Chairman, my colleagues, actually SGLT2 comes to stay with heart failure with reduced ejection fraction by all these trials for prevention treatments. For type 2 diabetes, actually, for CKD with DAPA, CKD, and EMPA, CKD, kidney. And then we are looking for the heart failure preserved ejection fraction, deliver heart failure, PAD, and Emperor preserved. And thank you very much, and see you in Alexandria.
Thank you, Professor Sobhy, for your elegant presentation from a cardiological point of view about the benefit of SGLT2 dapagliflozin in heart failure patients.